So now coming to the examination of wrist and hand. So it's basically a very small area, wrist and hand, and again a very superficial area. There are not much deep structures, there are not much structures covering this area. So whatever is there, that's easily palpable and can be easily tested. The only thing is that there are so many structures inside a small area, but the structures are too many. You have the bones, you have the radius and ulna, and you have then the carpal bones, the proximal and distal rows, the metacarpals and the phalanx. These are the bony structures. You have this functionally saying 3 bones over the proximal and 4 bones at the distal carpal bones. Then there are a lot of ligaments. So practically we may not worry about all these ligaments, but just understand that all these bones are covered from palmar dorsal side and palmar side. They are connected with ligaments, and there are interosseous ligaments, and then there are extrinsic ligaments that is coming from the radius and ulna towards the carpal bones. So only a few of these ligaments are clinically important, like all of them are important, but the usual culprits are a few of these ligaments. So we need not worry about all these empty number of ligaments. You can see these ligaments. Again, if you are going to name them and look them, there are so many. Okay, but always remember about the TFCC. TFCC, that's a pretty important structure, and you will get abnormalities quite often. Okay, that also is having a bit complex structure. We will come to that. So these are the ligaments and the disc, everything that is connecting these long bones to the carpal. Then there is a carpal tunnel. I'm not going to all of you may be knowing the anatomy. There is a carpal tunnel. There is the Guyon's canal. There is the 6 dorsal compartments. Okay. Muscles. All the muscles coming from the forearm to the hand, long flexors, extensors, the intrinsic muscles, the thenar muscles and the hypothenar muscles, and the nerves. Okay. So this is the area that we are going to examine. Basically, these are the things that are in and around this area. And you first inspect. You can see many things. You can see the deformities. I hope there is no need to explain these things. These are like spotters. You can see the wasting. You can see possible CRPS. You can see a ganglion. You can see a rheumatoid hand. You can see the deformities, 90-90, Butner, and the IP joint involvement, Schwannack, the muscle atrophy, interosseous atrophy, the rupture of tendons, nodules. So that's all in inspection, and you can see many more things. Okay, that's just examples. Now coming to the palpation. Now the important thing is the palpation. On the volar surface, 3 tendons, easy to find out. Doing like this, palmaris longus, flexor carpi radialis, flexor carpi ulnaris. These are the major tendons you can palpate on the volar surface. Then 3 bony prominences, again easy. The tubercular scaphoid, where is the tubercular scaphoid? Here the bony prominence, you are touching is the tubercle of the scaphoid. Then the pisiform, easy. This one is the pisiform. Hamate a bit tricky. You just move medial from the pisiform to this side. Try to press. It hurts. It hurts. At a point, it's just you will have a solid structure beneath and press it. It hurts a bit. That is the hook of the hamate. So these are known as the pillars on this side. That is the tubercle of the scaphoid, pisiform, hook of the hamate. Which structure may be attaching to this? As the carpal tunnel, transverse carpal ligament. Okay. So whenever you go for a flexor retinaculum release, usually you mark it prior to the surgery or this thing. You can mark the proper carpal tunnel. Usually you get the surface mark, and with the ultrasound also you can see the structures and you can have a proper marking. Then dorsal surface. What all things are there in the dorsal surface? Now let us find out the carpal bones. So how are you going to identify each of these carpal bones? So once you identify and you know how to palpate each of these carpal bones, then you will get an idea about where exactly the pathology lies. So the tenderness and all the problems at a specific point, you know that this is the structure that is lying below this point. So the surface anatomy is very important. Let us start from the thumb over here. So you know this one is the anatomical snuff box. You come down the metacarpal and your thumb just dips. You come down like this, your thumb just dips. Okay, that is the trapezium. That is the trapezium. Okay, then second we can take the capitate. Come from the third metacarpal, from here, come like this, again your finger dips. That is the position of the capitate. From here to here your finger dips. So here is the trapezium, here is the capitate. So in between here is the trapezoid. So now you have covered the trapezium, you have covered the trapezoid, you have covered the capitate. Now you know the hamate, hook of the hamate we told, here is the hamate. Okay, here is the hamate. Now let us go to which one? You will go to the lunate. How to find out the lunate? You come to the capitate, you know this dip is the capitate, just flex your wrist, something pops up, just proximal to the capitate, something pops up. The dip, you keep your finger over here and flex your wrist, something pops up, something touches your fingers. That is the lunate. Trapezium, capitate, trapezoid, lunate, hook of the hamate, scaphoid. You know the tubercle of the scaphoid, that's over here. On this side, keep it in slight ulnar deviation. Here is the styloid process. Just over here, you are holding the scaphoid. And actually you can move the scaphoid, holding the tubercle, and on this side, you can actually mobilize your scaphoid. Now a bit tricky bone that is left is the trichotrum. Okay, trichotrum again from the pisiform, as you slightly do like this, it's not that evident. From this you will again have a small pop-up, that is a trichotrum, but you can come from this area also to the trichotrum, that we will come. Now you have the another important thing is the 6 compartments. So the structures will be, first compartments, it's longus, brevis, longus, brevis, longus, abductor pollicis longus, extensor pollicis brevis, ECRL, ECRB, extensor pollicis longus, then the digitorum, AIP digitorum, extensor digiti minimi, and the extensor carpi ulnaris. This you can easily see. 1. So this will be which compartment? Huh? Now this is the first compartment. This will be the third. That's the third. So you go EPL, you go to this side over the third compartment, reach here. Just lateral to that you have a bony prominence. That is the Lister's tubercle. Okay. And then medial to this EPL, you have a dip. Just medial to ulnarwards to EPL, you have a dip. That is the scapholunate interval. That's an important point. That's an important ligament. So this dip is the scapholunate interval. Here is the scapholunate ligament. Okay. Then you have a slight broad area over here. So that is the fourth compartment. This broad area is the fourth compartment. Then you just extend your ring finger like this. Over here you have the fifth compartment. Okay, fifth compartment. That's the extensor digiti minimi. Okay. Then you have the extensor carpi ulnaris. That will be on the ulnar side when you keep it pronated. When you actually keep it supinated, that will actually move to this side. That is the extensor carpi ulnaris. That is the sixth compartment. So here you have the third and fourth. We said between the third and fourth compartment you have the scapholunate interval. And the fourth and fifth compartment, again, if you do like this, there also you can have a small dip like feel, that is the luno-triquetral interval. Getting confused? No need to get confused. So from this luno-triquetral interval, you are holding the triquetrum over here. So I am from here around the pisiform and here, then I can actually hold my triquetrum. Okay, so again I will come. So this will be the first one, first compartment, the third compartment. Radial to third compartment, you are getting the Lister's tubercle. Ulnar to the third compartment, you are getting the scapholunate interval. Then you have a broad flat surface for the fourth compartment. And between the fourth and fifth compartment, you will have the luno-triquetral interval. Then here is the sixth compartment, that is the extensor carpi ulnaris. So this much are the compartments on the dorsal aspect. In the palpation, now you know how to palpate individual carpal bones, and you know which are the major bony landmark over the dorsal surface. Then ROM, then before that, then in the hand you have the flexor tendons, everything. Then only one thing, what is the difference? I am flexing these two fingers. Where is the MCP, or where it flexes? Around the proximal palmar crease. When I am doing like this is around the distal palmar crease. So usually when you are going to inject for a trigger finger and all, you will see this will be here and this will be over here. Then you have the thenar eminence, thenar muscles over here, hypothenar muscles, then you have the intrinsic, everything. Okay. Now the ROM, no need to tell, you can measure the ROM. Use some small conimeter. Only practical point is, when exam comes, usually what happens, especially when you are going to examine the IP joint ROM first time in the examination, you will have lot of confusion where to keep this axis where. So make it a habit to measure the joint, small joints with goniometer. Somebody may ask you to measure it in the proper way. But again, have the rough assessment always before examining. This is a 0 degree, this is 90 degree. So in between this will be the 45 degree. So you must have a rough assessment beforehand, and then you can make a proper measurement. Strength and sensation, you can measure it with instruments, and you can have a rough measurement, 2-point discrimination, pinch and grip strength. Then the Tinel signs. Okay. So the Tinel signs, all the Tinel signs are not that sensitive. We just show that there is a regenerating axon. You can have it over the median nerve, or you can have it over the ulnar nerve. Then this Allen's test, again not a very good test, but it, to know the patency of the arteries, it is done. You compress, you just make your fist and release. Then you compress, you can either compress, the original test actually compress both the radial and release it, or you can do it for both radial and ulnar together also. Then this is how you detect a very small joint effusion. Press like this and you can identify the effusion. Or IP joints, you can actually, one way you press and the other way you can feel to know the small joint effusion. Different tests for the CTS, the phalanx, the reverse phalanx, and the nerve compression test. All of their sensitivity, specificity, these things varies. Okay, they are not, all of them are not having varying result and not very good, many of them. Then decurrent stenosynovitis. What's this test? Yeah? Finkelstein? Yes. There is a catch there. This test you see here is actually not a Finkelstein test. Always we think of it as this thing, as Finkelstein test. That is known as Eichhoff test. Okay. That's a common impression that we confuse it with Finkelstein. Finkelstein is a different test. Actually, these are the 3 steps of Finkelstein. Actually, this is not the original version of Finkelstein, but it's a modification later formed to Finkelstein. Actually, first just keep it ulnarward. Okay. Then you actually just have with your hand, you are just ulnarly deviating it. Third, you are actually deviating the thumb also like this. You never do like this. This is the Eichhoff test. The problem with the Eichhoff test is, this is maybe positive for many conditions over here. So this stretch can be painful for many conditions. That's not that specific. But whereas Finkelstein is more specific. And then there is another issue. What causes the positive Finkelstein test? That is mainly, it is said that is mainly the EPB that causes the positive finger stint. So there are resisted maneuvers with abduction and extension also. If you want to identify whether it is clinically exactly the abductor pollicis longus or the extensor pollicis brevis. So this is the modified, you can say something, it's not said that like that, but there's a modified version of the finger stint test. Then the Watson test. Watson test, because you hold the hand like this and you know how to stabilize the scaphoid over here. Okay, you know the scaphoid, and after stabilizing the scaphoid, you change the hand from ulnarward, ulnar deviation and extension to radial deviation and flexion. But you hold this scaphoid. So if there is an instability, the lunate will pop out with pain. So that is the scapholunate instability. That is a Watson test. Then lunotricutal instability. Again, you know how to, where is the lunate and the triquetrum. So here what is the thing is, you actually hold the lunate. Okay, hold the lunate, stabilize the lunate, and this triquetropisiform complex you actually try to mobilize. So you can actually mobilize it, or you can just try to shear force. So these two tests are for the lunotricutal instability. Then the TFCC. TFCC just stressing the area. You can see that ulnar deviation and stressing the area and doing the supination and pronation. That is one test, that is stress test. And the foveal sign is you are just pressing between the ulnar styloid and the flexor carpi ulnaris. You are just compressing over this area, and if there is pain, that is also suggestive of a TFCC involvement. Then the ECU instability, simple ice cream scoop movement and resist it. Doing a ice cream scoop movement and you are resist it, you can see either the subluxation of the tendon or pain. That is the for ECU instability. So I will just have a recap. So here we mentioned about the special tests are, one is the CTS, these tests, then decurrent stenosynovitis. The better thing is the Finkelstein test, and this is the non-specific Eichhoff test. Then the scapholunate instability Watson test, lunotricutal ballotment or shear test. Then the TFCC, the stress test and the foveal sign, ECU instability. Then the thumb carpometacarpal. So thumb, any problem with the thumb carpometacarpal, what you can do is, you can actually hold the scaphoid. You can actually hold the scaphoid here, and then you can grind or you can move, and you can see whether there is any problem with the carpometacarpal area. Okay, hold the base with the scaphoid at the base, and you can move the metacarpal. Then the thumb MCP. So what happens? So the clinical condition is this: the gamekeepers. What is a gamekeeper means? Game means this: those who deal with rabbits. When a rabbit is wounded, they do it. They actually hold its neck and do like this. Okay. So they will have a chronic repetitive injury of the ulnar collateral ligament of the thumb. So that is the gamekeeper's thumb. The same thing can happen with skies. So that is an acute injury, but a gamekeeper's thumb is a chronic repetitive stress injury. That's the difference. The culprit is same, the ulnar collateral ligament on this side. So there will be laxity. So how will you identify the laxity? You have to keep the MCP in 30-degree flexion and do the movement. So if there is a 30-degree movement, or if it is more than 15-degree compared to the normal side, this is positive in 30-degree flexion. So that shows there is a problem with the ulnar collateral ligament of the thumb. Then there is an accessory collateral ligament. To look for that, you have to keep it in extension, 0 degree, and then do the movement. So if that is involved, it's an accessory collateral ligament, otherwise it's the ulnar collateral ligament. Then other MCPs, again there are ligaments. Like this, there are ligaments. You can actually check this ligament in a 90-degree of MCP flexion. IP, these ligaments, actually you can do it in any position. They are taught in almost all position, and you can check for the laxity in any position. Okay. So it's actually a short exam. It's a short area. The only thing is that you must be well aware, or you must know how to identify all these structures. If you know how to identify all these prominences, all these things inside, then you can have a sense of where the problem is going on, whether it's a scapholunate interval or it's a lunotriquetral or there's a problem with the scaphoid. All these things you can make out. Then a short exam will be like, so this is close, and what you are basically doing is you are just checking the all the ROMs, and all the ROMs not only of the finger and wrist, actually you are checking of the elbow and also of the shoulder. As we mentioned in the case of knee, all the joints are linked together and the pathology may not be at the distal area. Okay, the original pathology may be somewhere else and you are having a manifestation or secondary thing in the wrist and fingers. So always have a rough examination of the proximal. Then after you have done that, then the palpation, focus on symptomatic area, strength sensation and the special test as needed. So you first do a rough examination of the ROM and rough examination of the ROM of all these area, find out whether there is something abnormal. After you have pinpointed out something, then go to the proper area and do the palpation, focus on the area, strength sensation and special tests. Okay, so it's the final session and I am stopping ahead of time. Thank you all.